because we know that obesity leads to more than a dozen different types of cancer. It leads to negative outcomes for ASCVD, stroke risk, and on and on and on and on and on. Why would we not want to call it a disease so that we can treat it aggressively?
The concern that most people would have is overtreatment. That's what the average person would say is, I don't have any health issues beyond my weight, so I don't want to be treated for anything.
This is Generation Health. We bring you the latest news, cutting-edge research, and time-tested best practices helping you live a longer, healthier life. Sitting to my right, Dante DiMatteo, PharmD. How are you, my friend?
I'm doing well. Thank you.
Excellent. And across from me, Joey DiMatteo, PharmD, board-certified clinical nutritionist. You look focused.
Very focused.
Good, good. It's a bit of a change-up.
Dialed.
And
We're
on
so dialed.
mic number 4, I don't like when you look at those buttons. It scares me.
Just doing my job.
Josiah Schweinberg, engineer extraordinaire, might be pushing buttons he shouldn't.
No, I'm just working on the levels, making sure everybody's clearly heard.
Okay. All right.
That's what you do.
My name is Tyler Andrews. I'm the host, and we've got some fun stuff. But first, I need to know, what smell instantly brings you back to your childhood?
Ooh.
I have a good answer, but you guys got to go first.
I don't know.
A lot of people go with like baking bread or a specific baked thing.
Yeah. So I have to think about it for a second, but I would say holidays with my mom.
Holidays with your mom.
Yeah, I think would be the way Christmas tree smelled and the cookies she would bake.
Yeah.
It just reminded me because she would have things going.
Did you guys do like the real tree thing?
No.
Oh, really?
But the house just still smelled just like Christmas.
Interesting.
My mom
We did the
was a
real
big
tree
Christmas
later
person.
on.
Yeah, we did.
I remember plenty of real trees.
My mom was really into Christmas, and it's gotten me, into it too. And that was just such an epic time of the year to be a kid.
That's cool.
Yeah.
What about you?
Man, I can't think of anything.
What about the smell of Dad cooking bison burgers when you came home?
Wow. True.
Yeah.
Did he do that?
Yeah.
Was that was a regular occurrence?
I mean, when he was cooking, it was either like bison burgers, maybe some all beef hot dogs, or when I was a little younger, it was pasta, tuna, and olive oil. Just literally canned tuna on pasta with olive oil. That's what he would, and I loved it.
Sounds like bachelor cooking.
That was definitely, yeah.
I got to say, for me, because I thought about this recently, it's that stuffy cigarette smell from stores or like apartments where somebody smokes a lot and it's never ventilated. Do you know what I'm talking about?
I do.
You don't smell it anymore because that's not a thing anymore. But I'm old enough that I remember there was a trading card store, sports cards and stuff, and the dude just sat in there and chain smoked all day long. It was one room, and that place, that's the smell that I associate with it. Yeah. And you know what made me think of it was I bought the first trading cards I ever got were Desert Storm trading cards.
So I knew they weren't sports cards.
No, they were not. They were Desert Storm trading cards. We
Wow.
had trading cards for our
like
war.
officers?
I don't remember now.
You had like Lieutenant Stevens on there?
Yeah, I saw
Wow.
them in a store
Wow.
just recently. In fact, I need to go by and see if I can buy a pack, and I'll share them with you guys.
There's nothing more American than that. I
Right.
like it.
That's yeah.
That says
That was
I
probably
love my
part of
country.
the-
Exactly.
Yeah.
Indoctrination.
I'm glad we don't make those anymore. All right, we got a bunch of stuff to talk about today, but one of the things we're really focusing on is this article research piece that just came out. This is from the Lancet. There's been an ongoing debate about whether or not obesity is a disease state or whether it's a precursor to disease states. And to some extent, especially bystanders, it feels like just kind of a, why does it matter? Why are we arguing about this kind of thing? But it does have actually substantial implications. And the Lancet organized a group, they called it the Lancet Commission, very creative title, of 56 different doctors to all kind of get together and figure out the best, most accurate way to approach all of this. They put out a big, huge summary paper that we've all gone through. and it's very intense and lots of reading. But there's some really interesting things that have come out of it, and I think we should go over that. So, Dante, what am I missing in my just initial explanation of what this is? Is there something I've glossed over that we should cover beforehand?
Not necessarily, but one, I think, important distinction for the listener is when we talk about the definition of obesity, I think it's important to make clear that we're talking about the definition in a more clinical context. It's one thing to have a general definition of obesity, and sure, the clinical definition and the general definition should closely match, but we're going to be talking about it more in the context of how do we actually nail this down into a repeatable, clear definition that clinicians and public health experts can use to, help inform decisions.
So currently, or previously, the definition of obesity was people that hit a certain point on the BMI. The BMI being a combination of height and weight, right? And once you passed a certain number, you were overweight. And once you passed another number, you were obese. And then that's it. Or does it go even higher than that?
Clinically speaking, right now, there are stages, depending on what guidelines or what country you're in. But for all intents and purposes, there are 3 stages of obesity right now.
Okay.
And those, and what we're going to ultimately discuss is what it became. So there's now.
Yeah, we don't have to belabor. Sorry. No, it's okay. We don't need to hang out on what it was because that's old news to some extent. But that's the rough idea. This is relevant. Why is it that the nuances of what is and isn't technically defined as obesity and why whether or not it's a disease state makes a difference? This actually made it helped me a lot to understand this.
The shortest answer is that you will likely undertreat people, whether you view it as a serious risk factor in and of itself, or you view it as a disease. If we risk not calling it a disease in a clinical setting, or we don't clean up the definition like they have attempted to do, then you run serious risk of public health policies not going in the right direction, individual patients not, being triaged into the right set of, treatment options, however you want to look at it. I think that's the scariest part.
That made a lot of sense.
Yeah, and along those lines with having a definition that was controversial, with it being straight BMI, I think you lose a lot of the good that you can obtain if the medical community as well as individuals are more comfortable that the definition is accurate. And so I think that's a big thing too, is cleaning up the definition, like Dante said.
That makes sense. I'll speak for a lot of people on the outside of the medical world. When you say it's a disease, that implies that I have no control over it and it just sort of happens to you. You're walking along one day and you contract it just like you contract the flu. And that always frustrated me. But what I didn't understand is that if it's a disease, then it needs to be treated. And if it's not a disease, well, then maybe it needs to be treated. Maybe it doesn't. And maybe we just ignore it. And so calling it a disease actually has serious implications for how it's responded to in a clinical environment.
Yeah, I agree. I think one of the big picture things that I took from this too is I think there's obviously always room for finding kind of the root cause. I think that's ultimately what there's a lot of that kind of mindset of, an obese person, quote unquote, has done this to themselves and those kind of things. And I think the focus should just be on, or primarily in terms of how we treat and handle it, is where are we now?
Right.
And what does this condition lead to for these people versus, this is what they should have been doing. This is why it's occurring, that kind of thing. So I think that's important too. For me, it was just to kind of center it around where we are. Yes, there's plenty of room for research on root cause, et cetera. But really, what do we do now?
Okay. So what is this new definition? How do we know if a patient is obese according to their new guidelines and standards that came out of the Lancet Commission?
So directly from their writing, the optimized definition of obesity proposed by this commission: obesity is characterized by excessive adiposity with or without abnormal distribution or function of the adipose tissue. Clarifies that excessive adiposity is the necessary condition for the presence of obesity. Abnormalities of body fat distribution, function, or both can be part of obesity and play major roles in identifying the effect of obesity on health, particularly due to their association with metabolic dysfunction.
Okay, so that doesn't actually help me all that much. They're saying if you have a bunch of adipose tissue, you're obese. And I think most people would go, yeah. I mean, yeah.
It's further clarifying that it's not merely the presence of the adipose tissue that signifies disease, as there is still the chance that you can live with excess adipose tissue and still not, kind of under the hood, not have many of the metabolic issues or experience the, physical issues that come with the load of excess weight, et cetera.
So how is it diagnosed then?
And so they look at BMI first,
okay,
as a screening tool, which is kind of how we've talked about it before.
Yep.
So BMI has to be over 30 in order, and it also, depending on your ethnic background, it varies.
Sure.
So you have to be over 30, and then also it needs confirmed by an anthropometric measurement.
Okay.
And so that's something like waist circumference or waist to height ratio. Or they're proposing even DEXA scan, some direct way of measuring body fat. See, that's where I sort of take issue.
Okay.
Is that my understanding, and there's a video from 2018, Barbell Medicine, who I've mentioned, I learn a ton from them. There's a video from 2018 of the main guy teaching you how to accurately measure waist circumference. Why? Because it was an adjunct tool, screening tool to BMI. So if you couldn't make sense of your BMI, which is why we're here, a lot of people can't quite make sense of that.
Right.
You need an anthropometric tool, i.e. waist circumference, to either confirm or deny or warrant further investigation as to whether or not obesity, the disease, is present.
You need more data.
Right. And this was 7 years ago.
Yeah.
So to see us still kind of in this limbo, it felt to me that we already solved this.
Why?
But right,
medically we hadn't, because
Right.
medically it's pure BMI, and I think that's because everything now gets polarized, and it's no, see, BMI is worthless, or see, BMI is everything. No, it's something in between. It's a great screening tool, and then the next step is one of those measurements that to kind of put a bow around it to make sure that it makes sense related to any type of diagnosis.
Yeah, it seems like the consensus for anything medical is at least a decade behind what the cutting edge research usually indicates.
Yeah, their quote is, "We recommend the BMI should be used only as a surrogate measure of health risk at a population level, rather than an individual measure of health." So it's kind of it's a broader screening tool, and then for the individual, you take one of those measurements and then make a clinical decision.
Interesting. Okay.
I guess it's just the guidelines prior weren't explicit enough. But if you look in 2016 guidelines from AACE, medical care of patients with obesity, it still references these confirmative markers. It's not telling you that the buck stops whenever you catch somebody's BMI out of range.
No,
you know what I mean? So it's like, it's just, we were already almost there. It just feels like, I think a lot of practitioners are kind of already doing this.
Yeah.
But
I
maybe
would
not
imagine.
enough. Maybe not enough.
And it's good to have it formalized and verified by the official bodies, because I know, like, life insurance, they don't care what your waist circumference is. They just care about BMI. That's it. And based on your BMI, they're gonna rate you a certain way, and that's the end of the conversation. And it doesn't make sense for a lot of applications, but when there is a formalized statement from major groups like this, you have a better argument when you go, hang on a second, this says I'm not, by these guidelines.
Yeah, it's kind of non-controversial. I guess that's maybe the nicer way of saying what I'm saying, is that it's sort of non-controversial. There are I don't know if this becomes the norm.
Yeah.
You know, I don't know if every single governing body or every single medical society adopts this, but I think I saw that 70 plus.
I was gonna say it's been adopted by a bunch.
You know, so it is the way of the future, I guess. It's just I don't know. In 2018, we were not me necessarily. We were kind of already saying that, hey, good practitioners are already employing these secondary measures to BMI.
Fair enough. Okay, so let's talk about is it a disease? Is it not a disease conversation? What is the downside of calling it a disease? If the point of calling it a disease means that we're going to treat it aggressively and try to eliminate it, because we know that obesity leads to more than a dozen different types of cancer. It leads to negative outcomes for ASCVD and stroke risk, and on and on and on and on and on. Why would we not want to call it a disease so that we can treat it aggressively?
I think the risk, the concern that most people would have is overtreatment. And overtreatment being a controversial way, but I think that's what the average person would say is, I don't have any health issues beyond my weight, so I don't want to be treated for anything. And I think that's where ultimately this starts to get down to, how do we proceed from here?
Okay. So the element of I don't have any issues beyond my weight, I seem to remember there being something about that in all of this.
Preclinical obesity is a state of excess adiposity with preserved functioning of other tissues and organs.
Meaning everything works the way it's supposed to.
Yes. That's kind of the example I brought up is, yes, I know my weight's like this, but my blood pressure's fine, my liver's fine, my kidneys are fine. How do you convince potentially somebody like that to maybe get treatment for, weight loss, for any maybe possible blood sugar issues that are starting to arise, maybe have a lower goal for LDL, et cetera? How do you maybe recategorize them, and still without upsetting them and giving them medications or treatments that they don't want? So it's I can see why somebody would. So again, my initial thought is, the risk of type 2 diabetes, cardiovascular disease, certain types of cancers is, to me, would be worth that risk.
Right.
But there's other people that just don't want intervened early. And so that's why I think first step was cleaning up the definition. Because if you start getting rid of, hey, I know my BMI is 37, but look how big that kind of stuff, you start cleaning that up. And so it's something that can be more, I think, accurately diagnosed, and that people are comfortable when they're put in that bucket. And then from there, how do you communicate that their increased risk is reason enough for treatment? And and it's all individual. Doesn't mean every single thing you check a box and do. But to me, I think that those risks are, type 2 diabetes, cardiovascular disease, cancer risk.
It kind of has really boiled down to an intense argument of semantics, basically.
Yes, that's it all seems very semantics oriented.
Those in opposition of even calling obesity a disease, it's basically that, you can't just explain this without saying, oh, your risk of type 2 diabetes, this other thing increases. Oh, cardiovascular, that's not directly the disease. And so kind of like everything else, you talk about hypertension, you can explain that you can get into the whole pathophysiology of hypertension, and you can directly measure it, and you can see the damage and the inflammation that it's causing in vasculature, et cetera. Much easier to define. The presence of bacteria in the lungs, is it some sort of infection? You can measure it. The argument is that this is different. We just, we can't actually separate obesity like those other conditions. And with the new definition, this reframing, it's sort of like, hey, you can. We can talk about it in and of itself and show all these debilitating things that the excess, adiposity is causing, or
could cause.
It's just in and of itself it's just inherent to the disease.
Yeah.
Versus like, you're just running the risk to all these other, these other issues. So that's what's I find interesting.
So they came up with clearer guidelines on how to diagnose it, to officially state, yes, you are obese, No, you are not. But then they also, you mentioned preclinical. They broke it into two different segments, preclinical and then clinical obesity.
Mm-hmm.
What is the difference?
Preclinical, you don't have a secondary health issue.
Okay.
So you hit the marker, you kind of the BMI screening, then one of the other measurements, waist circumference, et cetera. And then from there, if you have cardiovascular disease, if you have type 2 diabetes, you go into obese. If you don't, it basically, the way I view it is you're put into a higher risk category.
Got it.
That would be the way that I would assume it would be approached as, again, potentially they look at a different LDL level. They look at a different goal for blood pressure, et cetera.
That's what I don't understand.
Okay.
Is that it doesn't, they're trying to get away from that, is my understanding. That it's not about specifically the cardiovascular disease, type 2 diabetes. It is signs and symptoms of ongoing organ dysfunction. They're trying to delineate that so it's not as overt as like C, type 2 diabetes, C. It's because currently that's the issue. If you have a BMI, you have to have, let's say you want to meet the criteria for an FDA indicated medication like Wegovy, you have to have a BMI of greater than 30, or you have to have a BMI of greater than 27 with another excess adiposity associated chronic disease. They're trying to get away from that so that we can say, hey, this in and of itself is like this separate thing that doesn't necessarily mean cardiovascular disease or diabetes. Now, what those things are sound like, they kind of sound like these other things. But for example, clinical manifestations of organ dysfunction directly caused by obesity in adults. Musculoskeletal. Osteoarthritis, particularly affecting large weight-bearing joints such as the hips and knees, develops as a direct effect of body size on these joints. Weight-related metabolic and inflammatory factors contribute to the direct mechanical burden. Mm-hmm. Upper airway obstruction caused directly by obesity results in the development of disordered breathing. Respiratory, the physical effects of increased intra-abdominal central adiposity on diaphragmatic compliance and lung function. So these are cardiovascular. The relationship between obesity and cardiovascular disease is not well understood due to the presence of multiple overlapping risk factors. However, there is emerging consensus based on certain studies that aggregated exposure to excess weight can, over many years, lead to atherosclerotic cardiovascular disease.
So I guess also there's a little bit of semantics too. So are they defining preclinical obesity as a disease state? Or do they only say it's a disease state whenever you get diagnosed?
That was my understanding, is that preclinical obesity was you meet the markers for obesity, but you have no other issues.
Right.
Therefore, hey, heads up, you have crossed that line, but you're not clinical, and therefore we don't necessarily need to treat it aggressively. Mm-hmm. You should look at lifestyle changes. You should talk to a counselor. You should yada, yada, yada. But we're not going to start writing a script for that, versus somebody who meets all those numbers and then also has these other ongoing health issues of some variety or another. And they can go, okay, look, here's the deal. Your obesity is now affecting your health, and it's already being harmed in these different ways. We've got to treat the obesity as a disease because it's now clinical, air quotes, obesity.
And what they specifically state is people with preclinical obesity should undergo evidence-based health counseling, monitoring of health status over time, and when applicable, appropriate intervention to reduce risk of developing clinical obesity and other obesity-related diseases.
There you go. Yeah. That was my understanding.
So yeah, it appears that they're not recommending any specific treatment besides counseling and monitoring for preclinical.
Right.
Mm-hmm.
So
in prior with the old staging, stage 1, 2, and 3, they're essentially doing the same thing, but it is now, if you were stage 1, you were obesity with no obesity related complications. Stage 2 is obesity with one or more mild to moderate obesity related complications. And then stage 3 is one or more severe obesity related complications. Okay. So this just does simplify that to basically it just makes the treatment group much easier to hit that threshold. Whereas stage 1, 2, and 3, it's kind of like you're kind of playing a game essentially to get if somebody who's maybe interested in surgery or they feel is a good candidate for surgery or a good candidate for medicines, then you're like trying to find as many conditions to nudge them closer to a treatment. Whereas now, because it's less about comorbid conditions and literally like we're more clearly defining the cause and effect relationships of certain disease states with that the excess adiposity is causing, that like if the drug companies change their indications, it's going to cast a bigger net.
Yeah.
Is I think what ultimately happens here. They talk a lot about over-diagnosing, which is let me just read what they said.
No way. Yeah.
I mean, they did mention, I feel like it's kind of like they have to mention that there's a chance for over-diagnosis with the way that it is, but I just thought this was funny.
Yeah, I think the new way eliminates the vast majority of over-diagnosing. Now, the second layer is over-treatment of of what you do with that information, but the actual over-diagnosis of obesity
there's
itself,
just no way.
Yeah, go ahead.
There's plenty of data. There's plenty of data to show that we're missing people based upon the BMI-centric approach. So it's just BMI can overdiagnose obesity. Famous examples of such misclassifications are legendary boxers and U.S. National Football League quarterbacks.
It's an extensive
if
list.
That's the example. That's a very small swath of the population.
Yeah.
It's just like, we're not really, it's in practice, it's very doubtful that you're that jacked,
And once, especially now that they add that second layer, there's just
no way.
Yes, and I think that's what's critical, again, back to the beginning, is the proper definition.
Yeah.
So imagine you're a doctor, you see 15 people in a day, and 3 of them are obese, kind of check all the boxes. Then you've got these other 5 BMIs where you're like kind of warning this, we'll call it a jacked guy, maybe more in the unlikely thing, but say we got a few of those.
Sure.
And so it just muddies up versus like, hey, yes, your BMI was high, but waist to circumference ratio, you're hitting this too. And no, you don't have any of these yet, but that's why you were considering you preclinical obesity. We're not going to do anything right now, but just understand these are your risks. I think that like, do you think that it's simplified it? Do you think it's an improvement versus what they had?
I think it is definitely an improvement, 100%. But I guess I'm speaking to my bias, is it felt like it already existed this way.
Okay.
I'm like, who in the world is not looking at who that is practicing obesity medicine is not using a secondary factor to confirm, deny, relook at BMI. There's just no way
Makes sense.
that I believe that it took this for people to say, oh shoot, no way, but no, you're right. It is, I'm with you. This is absolutely better. It's just going to drive people nuts semantically, again, because of just when I seemingly disagreed with Joey, it was just me saying that, no, if you read this, you're going to find out that it says we are distinctly going to talk about comorbid conditions like we do other diseases and the directly obesity related diseases. See, you're like, wait, you said the same thing, right? Isn't that the same thing? No, they're trying to distinguish that. And so I think you can kind of get lost in the weeds with that.
Yeah.
I feel that that's less important, again, because you have clinicians making what I think are kind of good decisions anyway. And whether it's in a comorbidity or in a direct cause and effect sort of relationship, you're still going to end up in the same, now with this bigger net, you're still going to end up more likely intervening on that same person under, you know what I mean?
Yeah.
No, the one thing that I wanted to add to the FDA, I brought up FDA indications for the medicines.
Uh-huh.
So what I'm about to say,
Ozempic, Wegovy.
Well, technically Zepbound and Wegovy.
The GLP-1 agonists.
Right. Yes.
Okay. All right.
Exactly. Yeah. So Ozempic, Mounjaro, they're the FDA approved trade names for the type 2 diabetes. Zepbound, Wegovy, although they're the same active molecule, they just have a different name because they have a separate indication.
Technically indicated for obesity. Got it.
Yes. So why I think it will take some time, but unless I'm really missing something, I see the biggest impact in this situation. So again, currently, in order to meet the technical requirement for your insurance to pay for a weight loss medication like Wegovy, BMI has to be above 30, or you have to be above 27 and have the presence of a comorbidity, cardiovascular disease, type 2 diabetes. Now, there are a chunk of people whose BMI is 26, 27, and their insurance, and they can't, they're too young, or maybe they can't quite through lab markers show that they have some sort of elevated something. They can't prove that there's really much going on under the hood. But if they would have just taken a waist circumference, you would have seen that maybe it does nudge them into a place where they could have been treated. Their insurance could have paid for the medication. It seems like a small gap, but I think it's a big gap. I think if your BMI is not over 30, that doesn't automatically exclude you from something like bariatrics or you know what I mean? Or one of the medicines that have really been helping people.
Well, and it seems like making this more accessible helps to prevent people from feeling like they need to game the system and go, oh, well, I'm not quite there. All right, give me a couple months. I'll get over that line.
Oddly enough, yeah.
Yeah. And with some of the changes with
which is
insurance,
not good. You don't want to do that. Don't play the game like that.
Yeah. It's probably a small percentage of people, but people maybe who were at 32 lost weight and are on it, and now they're at 27 and their insurance.
Oh, interesting. I didn't even think about that.
Yeah, again, it's a smaller percentage, and that's the next level of how aggressive the doctor's office is and kind of documenting all that information. But there's that element too of people that dropped below, but they only dropped below largely because they're on the medication.
So people could lose coverage because it worked. But oh my gosh.
You have to get those redone. Those authorizations where you get approved for 6 months, 3 months, 1 year, they need redone. And a lot of insurances, at least in our area anyway, coming into this year, kind of just because it's like anything else, it's about money.
Yeah.
The burden, those drugs are anywhere from $1,000 to $1,300, $1,400 a month every 4 weeks. So they don't want people kind of gaming the system, however it may be. Well, look at my BMI, all that stuff.
Right.
So it's
this, when we first started talking about this, it seemed like so much silly semantics debate, but having spent some time with it and digging through it, I understand why this is so important. It's one of those things where when you're outside, you go, what are we arguing about? But the people that are inside are really passionate about it for a reason. Mm-hmm. And it's that knowledge gap of when you understand all of the implications of one word change or one definition change, it makes a big difference. And it sounds like this is mostly a good adjustment.
And look, in the end, I think I don't want it to get lost that I could just stay. I don't believe, and I don't think the evidence shows this, that you can just sit in a preclinical phase forever. I think as waist circumference increases little by little, as you have, just like high cholesterol, just like hypertension, as you're hyperglycemia, as you're exposed to those sorts of things, the longer you go, the more likely you are that this progresses. So simplifying it into 2 buckets, doesn't mean that if you're in that first bucket, it's like, well, they're not going to do anything for you now. Yeah. No, if anything, it's kind of the opposite. We're still lobbying for, early intervention, albeit maybe a bit more conservative. Mm-hmm. But it's just, I could see a lot of people saying well, how, what are you saying? People can just be preclinical forever. No, I don't think that's usually the case. It is possible. Right. But we still need to.
In the same way that you might know a guy who smoked for 70 years and never developed any breathing issues at all. It's possible. Yeah. Real unlikely.
Yeah, and I I think they sum up something along those lines pretty well. Although the risk of mortality and obesity-associated diseases can rise as a continuum across increasing levels of fat mass, we differentiate between preclinical and clinical obesity for clinical and policy-related purposes. Yes. The continuum is the key. The continuum to me is a fact, But at what point do you have to turn those facts into practical application?
Right.
And they're kind of saying we got to divide it up somehow, and they did 2 instead of 3. And
There's got to be a line somewhere.
Yes, but the continuum is key. That was a great point.
Exactly. The preclinical to clinical progression is as arbitrary as it sounds, right? Like it is 100% as arbitrary as it sounds, but it has to be that way, in the same way that if this blood level is 24 and you're normal, and then when you go to 25, it's high. You got to, like you said, you draw the line somewhere. Clinical and policy, they need to be able to get their footing somewhere in that. But then it boils down to the individual clinician. If they see the 24 to 25 thing, they see preclinical to clinical, there's still going to be a conversation. There's still going to be intervention of some kind. There's still going to be something going on to help prevent the progression or
the art of medicine.
Exactly.
The only thing that I can think of that we haven't covered yet is the study also spent a lot of time talking about the public perception and people's feelings about being diagnosed as obese, and the way it seemed very concerned with stigma and the way that the stigma of obesity can play a role. And so we don't want to diagnose somebody unnecessarily because they might have some stigma. And when I read it, maybe I'm just a jerk, but that's not maybe. I'm a jerk. But my thought was, I'm sorry if it hurts your feelings, but I'd rather have you alive. And that can be helped potentially by having this diagnosis so that you can go take action.
Right.
What am I missing in the stigma conversation here? 'Cause I don't think all these people are just out of their minds. I'm missing something.
I think the stigma part has many tentacles to it, because then the other end of that is, see, obesity is a disease. I'm overweight. I can't work out because of this and that, and I try to eat good. It doesn't work. I have a disease, and you just kind of roll in it's a disease approach of like basically do nothing.
I'm helpless.
Yes, I'm helpless. I have a disease. It's no different than any of the diseases we've mentioned. I contracted the flu, so that's what I'm stuck with, just like I'm stuck with obesity. I think that's where, again, in this polarized society, that's people are going to read this in one way and say, oh, we need to make sure that it's treated medically and that there's a diagnosis and almost like not a coddling of it. That's not the right word, but a very sensitive approach. And then there's the other end. They're going to come in on the hard line approach of, disease is not a disease. You eat too much. You need to get off the couch.
Yeah.
And the truth, like so many of these things, is in the middle of how to, again, back to what I said earlier about, so root cause still to be unpacked, but where are we now? Bottom line is we know that it leads to these, and you may be at a varying stage on the continuum of what disease state it is, physical or physiological, but what do we do now given what we know and where the person is now, not what caused it?
Right. How you got there is less relevant than where we go from this point on.
Mm-hmm. But it seems like a lot of the focus is on how we got there. From kind of the one end of the more the hardline stance on this, it's a lot of how we got there, I think.
Yeah.
Yeah. I feel like we have had this conversation. This thread is, again, just given how prominent the medications are. I think this comes up time and time again. But one of our recent episodes that came out talked a little bit about this. It almost is just kind of, the vibe that I got from this was kind of like, hey, we don't really care about these conversations. We don't really care how you feel, because whether you like it or not, there's just an inherent bias baked into society. Whether you like it or not, it's there, period. So what we're going to do, because the evidence points this way, is that we must medicalize it so we have some footing to talk to insurance companies, to talk to public health, to inform clinicians how to talk to their patients. It doesn't matter how you feel, because the evidence points to there being something going on because of the environment, because of the way that we evolutionarily conserve our body weight,
energy
at a higher than healthy level, that this goes well beyond what that person did or didn't do. There are numerous genes. There are numerous things, that you're up against in order to yeah, sure, it doesn't absolve you of action or responsibility completely.
Right.
But there's just that, how did they say it? Energy balance is achieved and defended at a higher than healthy body weight.
Say that. Okay.
So energy balance.
Right.
So we're talking, okay.
Calories in versus calories out.
Calories in versus calories out. If we want to really, really dumb it down, energy balance is achieved. Then once you get there, it is the mechanisms of your brain and these different pathways in your gut, etc. It is then defended at that unhealthy body weight because of the evolutionary mechanisms that are at play because of starvation and because of the way the world once was, that you basically, as soon as you deviate or you enter a caloric restriction of some kind, that hunger signals go off the rails, emotions go off the rails, energy expenditure is ramped down.
Yeah.
So how in the world is this not a medical discussion? It's like this isn't directed at anybody. It isn't directed at anything. It's just like it doesn't matter kind of how you feel. It really doesn't. It just is what it is. We know that these things have occurred, and we know that people are up against things that they literally cannot control, let alone, we didn't even talk about the environment yet.
Right.
Yeah, I agree with everything you said. I think it's really well said. I guess the one little nuance is we need to have these conversations. These things that seem black and white need to be unpacked because the bias is so strong and so inherent. So I know we've talked about all those things, but I do think it's important, and even like little different approaches to this is because the bias still is there, and it's going to take time to get over that.
And as true as everything you're saying is, it's also still true. It doesn't hear me. It doesn't matter how you got there. The important thing is you have to take action to improve your situation.
Exactly. Yeah, I agree.
Whether it's all your fault or not isn't really relevant. What's relevant is what you do now.
Yep.
And hopefully with some help, we can make change. That is fascinating. That specific wording though, that makes sense because it's I've experienced that myself. Your body wants to, wherever it is, your body just wants to stay there.
Yeah. I'm just going to read it again.
Yep.
In exactly what they say. The biological process of fat storage, largely as triglycerides, is evolutionarily conserved to prevent starvation. The body responds to weight loss induced by hypocaloric diets through a robust defense mechanism, which increases hunger and the desire to eat while decreasing energy expenditure. This mechanism seems to be mediated in part by gut hormonal responses and reductions in fat-derived hormone leptin, which interact with regulatory regions within the brain to establish a set point equilibrium body adiposity. The equilibrium body weight is fiercely defended by the brain, whether the set point represents a so-called healthy weight or an excessive degree of body fat in people with overweight or obesity. It's not everything, but that is the most scientific way to talk about what the heck people are dealing with every single day of their lives.
That's
right.
Well said. And I think too, what potentially could come out of this, if you ever had somebody walk in the pharmacy and say, you know what, I went to my doctor today, I'm stage 1 obese. Have you ever heard that? How many times have you heard I'm pre-diabetic? Whether you agree with it or not. Right. So I think potentially, back to like the theme of like cleaning up the definition. Clinical obesity, odds are those people already have already been diagnosed, they're being dealt with. But how many people now with something that's a little more firm, potentially, we haven't seen it yet, but potentially, I got told I was pre-obese. I have preclinical obesity. And looking at that, they can't maybe just poo-poo the BMI thing anymore because they also did another marker. And hopefully it could be something to elicit more change one way or another. Because I do think it's going to have a little more bite than it did before. Even though like nuts and bolts, not much has changed, I think potentially this could just be a more practical way to approach it.
I completely agree. I think the preclinical clinical thing is much better than the staging. I think clinicians who are practicing in this, which we aren't, are used to it. And they're not the ones telling patients, hey, you're stage 1 or you're stage 0 or you're stage this. It's kind of they just do their thing and they use their art to essentially tell somebody where they are. But you're definitely right. I think it was, meticulously chosen. I think so.
I agree.
I really do. Yeah. It just seems like the more we riff on this, like there are still like little things that are probably worth talking about.
Go ahead.
We talked about the whole waist circumference thing. We said, hey, in 2018, this was being talked about. Before that, it was probably being talked about. So first of all, some people there are good videos on how to measure your waist circumference. What's like a practical takeaway? If you're the type of person you want to know where you sit, I guess, relative to this, if you're listening, then yes, you can simply punch in your height and weight and you'll get a BMI. And then if you have a tape measure or a string or whatever it is, there's a certain place on your abdomen that it's not waist circumference in the sense of what size jeans do you wear.
Right.
It's a very specific point on your body that's important to get right. And so that's actually kind of a rebuttal against why something like this may not be great in practice, because then you're having to train people to do this. So if you tell, hey, before you come in your appointment, I want you to bring me your waist circumference, it could be 2, 3, 4 inches off, and then you're back in the same boat of potentially misdiagnosing, overdiagnosing, that whole thing. Secondarily, medical assistants, nurses, whoever, that's another, when they take your blood pressure, it's really easy to walk into the doctor's office and the first thing you do is you stand up against the wall and then you step on the scale. Now you have to lift your shirt up and you got to put a gown on, and then somebody has to stand behind you and potentially measure it. It would be awesome if you could just walk in and they just take your picture and it's like, boom, you could see where this fat's accumulating and you can see this, and it tells you how tall you are. It tells you how it can see your muscle, where it tells you if you have subcutaneous fat or if you have visceral fat, like a DEXA scan would. Mm-hmm. And so we're not there yet. We're a ways off from not only that, but we're a ways off from, widespread DEXA scans and PCP offices.
Yeah.
So we just have to figure out how to make the waist circumference thing work. And so I think for people who are interested in measuring maybe progress that they have made, or, they just want to know, just Google how to measure your waist, use that with what your BMI score is. And then you have a really realistic picture of what the next steps are.
Yep.
Yeah.
What gets measured gets managed.
Exactly. And so you might even be asking again, the adiposity that accumulates around the abdomen, like what's the deal with it? It is more dangerous. It is harder to store excess adiposity on your legs, on your arms. It certainly can accumulate there subcutaneously, but there's more room, more expansion, more can occur. And so that is thought to be one of the mechanisms by which adiposity preferentially selects the abdomen. Also, there's just a whole genetic component that is well beyond the scope of this conversation. Why John over here his body fat accumulates this way, and why mine does this. And within families, there's some differences.
Right.
Once again, there's just certain things that you do not have control over, period. Or as much control over as we once thought.
Right. Not black and white. Exactly.
And so then the visceral adiposity is why the tissue around the abdomen is why you're literally measuring that area.
Yeah.
There's another measurement, another calculation that's been proposed within the last 6 months to a year. Body roundness index.
Okay.
And so this, I made sure to check, but this article does not talk about that because it almost just seems like it's possibly overkill. Body roundness index takes into account all the same things that we talked about: BMI, demographics. Again, your ethnicity. Mm-hmm. Ethnicity matters in terms of different cut points. Southeast Asian, Northeast Asian might have a lower point at which you would want to intervene. Things like that.
Right.
Body roundness index basically takes waist circumference, takes BMI, takes height to waist to height ratio, hip to. There's even a waist to hip ratio. It takes all of those things into consideration and then spits you out a number from 1 to 20 or something.
Sure.
And so is it really necessary? Probably not, because again, you still sort of get everything that you need from just the two quick measurements, right? And again, we know we care a little bit more about the tissue that accumulates around the abdomen.
Yeah. It's an important conversation. This has been, I didn't know how long this segment was going to last when we got started, but it feels like we could just keep going all day and still not have covered quite all of what's in there. If you're interested and you want to read about this, we'll have a link to the actual Lancet article down below or in the show notes. If you liked what you heard, you want to follow up, maybe catch some more of this, go to our website, askjoedimatteo.com, askjoedimatteo.com. That is where you can find this episode, the show notes. You can find our email newsletter to be kept up to date on anything that's happening, articles, blog posts, new videos, old videos, and the sales for all the products that we have available there. Buying that stuff really helps us out and keeps this show going. Thank you so much, guys. What else? I'm going to forget something. Big thank you as ever to everybody around this table and to all the folks that are not around this table. If you like the show, give it a thumbs up, leave a 5-star review. We'd love to hear from it. Send us your questions. That's what I'm forgetting. Questions at askjoedimatteo.com. That's questions at askjoedimatteo.com. Thanks again. We'll see you next time.